In this presentation, I will be talking about the association between dietary and serum cholesterol and cognitive function. This study, published in 2023, focused on the effect of dietary and serum cholesterol on cognitive function in the U.S. elderly represented in the NHANES 2011 to 2014 survey. As individuals age, cognitive dysfunction and dementia become increasingly common in the United States. Alzheimer's disease is the main type of dementia, and progression from cognitive decline to Alzheimer's is continuous and irreversible. Thus, early intervention through lifestyle changes or rehabilitation therapy can be recommended for protection against the disease, particularly during its prodromal stage known as mild cognitive impairment. Several clinical studies have shown conflicting conclusions on the effect of cholesterol on the body overall. Cholesterol plays a crucial role in essential bodily functions such as the formation and maintenance of synaptic connections, the communication between neurons and cognitive processes, and neural recovery and prevention of mild cognitive impairment during compensatory repair processes after damage to neural pathways. However, cholesterol overload has been shown to lead to vascular and microvascular diseases that have adverse effects on cognition. As a result of these findings, this present study was conducted to better understand the association between dietary or serum cholesterol and cognitive performance in older adults. Most studies conducted prior to this one did not consider the participants' total serum cholesterol levels, had varying definitions of hypercholesterolemia, and focused primarily on participants' intake of dietary cholesterol. This investigation specifically aimed to examine the association between dietary cholesterol intake, supplement cholesterol consumption, total cholesterol levels, serum cholesterol-related indicators, and cognitive performance, with the objective of identifying targeted interventions for the prevention and treatment of cognitive impairment in older adults. Additionally, given the limited literature on the influence of ethnicity on the association between cholesterol and cognitive function, the researchers further analyzed whether these associations varied between non-Hispanic blacks and non-Hispanic whites. Overall, they hope to explore effective interventions for preventing or treating cognitive impairment and Alzheimer's disease in older adults. For this cross-sectional analysis, the researchers used 2 cycles of NHANES data obtained from the 2011 to 2012 and 2013 to 2014 surveys that included information on dietary cholesterol, serum cholesterol, and cognitive performance. The CDC's Ethics Review Board approved all NHANES programs, and all participants provided written informed consent. The NHANES data included complete cognitive performance scores, dietary and serum cholesterol-related information, as well as other important demographics. A total of 759 participants of the survey had complete data that constituted the researchers' analysis dataset. All participants were informed by their doctors whether they had hypercholesterolemia or not, which increased data accuracy and reliability. During each cycle of NHANES, participants reported their detailed dietary intake for 2 24-hour periods. A nutrient analysis was conducted to determine energy, nutrient, and other food components consumed. An in-person interview was conducted during the NHANES visit to collect the first 24-hour recall, and a telephone interview within 3 to 10 days collected the second 24-hour recall. In the analyses, the researchers calculated the average estimated dietary cholesterol intake during the 2 recall periods, or enrolled only 1 recall if there was no second recall available. Supplement use was also recorded. The laboratory indicators, which included total cholesterol, HDL cholesterol, and LDL cholesterol, were obtained from all enrolled participants. Serum samples were extracted in the morning and sent out for testing. Cognitive test results of these participants were also recorded. Trained examiners conducted assessments at the Mobile Examination Center using a 3-part cognitive test. The first part was the consortium to establish a registry for Alzheimer's disease word learning test, which evaluated memory through immediate and delayed word recall. The second part, the animal fluency test, assessed semantic fluency and executive functioning by having participants name as many animals as possible in 1 minute. The third part, the digit symbol substitution test, measured processing speed, attention, and working memory through symbol number pairing. Participants who scored below the minimum quartile on all three tests in their respective age groups were defined as having poor cognitive performance. The researchers used EmpowerStats version 4, a statistical analysis platform based on R software for data analysis. In addition to the target-independent variables, which were cholesterol-related indicators in diet and serum, and the target-dependent variable, which was cognitive test scores, this study also involved multiple feature variables, including age, gender, ethnicity, income level, education level, smoking status, drinking, doctor hypercholesterolemia notification, and doctor prescription guidance. The researchers examined associations between each test score of cognitive function and each feature variable. The researchers used non-weighted Spearman correlation tests to explore associations between continuous form feature variables or target-dependent variable and cognitive performance. To determine possible nonlinear correlations, they further examined the data that were transformed into quartiles or categorical form using Kruskal-Wallis tests or chi-square tests respectively. To allow for potential confounding due to the association between fat and cholesterol, they first evaluated the correlations between dietary fat intake and dietary cholesterol. Then they examined the associations between cognitive scores and dietary fat intake. To estimate correlations between targeted variables with each part of the cognitive test, the researchers used a linear regression model. They also selected potential confounding variables using previous results from Pearson correlation and Kruskal-Wallis tests and adjusted for these in the linear model. Finally, they conducted stratified linear regression analysis to evaluate the associations between serum cholesterol-related indicators and cognitive performance separately among non-Hispanic whites and non-Hispanic blacks, in which they excluded ethnicity and included only age, family income, education level, and prescription guidance as covariates. T-tests were used to compare differences in cholesterol intake between the populations from non-Hispanic whites and non-Hispanic blacks. The majority of participants were non-Hispanic whites aged between 60 to 69 years old, followed by non-Hispanic blacks. About 1/4 of people had a normal or underweight BMI, while 1/3 was overweight and the rest obese. 2/3 drank alcohol less than 5 times per month, while an equal number smoked more than or less than 100 cigarettes in their lives. A high school education was most common, and 45 participants of the total had only one 24-hour recall. Unweighted Spearman correlation analysis showed no association between cognitive test scores and dietary cholesterol intake, but significant correlations existed with age, serum total cholesterol, serum HDL, and serum LDL. Kruskal-Wallis tests revealed significant differences in almost every cognitive test among quartiles of serum total cholesterol, but no difference in HDL and dietary cholesterol intake. Unweighted Spearman correlation analysis indicated that dietary cholesterol may be correlated with dietary saturated fatty acids and serum HDL, but dietary fat was found to be almost unrelated to cognitive function. Participants were classified into groups of poor cognitive performance and normal cognitive performance based on cutoff points. Using chi-square tests, significant differences existed in the incidence of poor cognitive performance among groups of gender, ethnicity, education level, and income level. Many participants were on cholesterol-lowering medication, complicating the use of clinical cutoffs. Therefore, quartiles were used to capture potential nonlinear associations and ensure balanced, robust analysis. The linear regression model for individual cognitive test scores indicated that higher cognitive test scores had no association with dietary cholesterol, while a significantly positive association existed between higher cognitive test scores and serum cholesterol-related indicators. 4 specific variables, age, ethnicity, income level, and education level, consistently exhibited significant correlation with cognitive function. Thus, these variables were included as covariates in the regression analysis. However, similar results were still observed after adjusting for these covariates. Due to a small sample size of non-Hispanic Black participants, the researchers did not further investigate the relationship between supplement cholesterol or total cholesterol intake and cognitive function in different ethnic groups. When examining the effect estimates of serum indicators, it was discovered that non-Hispanic whites participants had strong correlations between serum total cholesterol and cognitive function in almost all tests. However, in non-Hispanic Black participants, there was no observed association between serum cholesterol-related indicators and cognitive function. This study showed that higher levels of serum total cholesterol, but not dietary cholesterol, were significantly associated with improved cognitive performance in memory, language, and executive function among individuals aged 60 years and older, highlighting a potential positive influence on Alzheimer's disease-related cognitive decline. The researchers speculated that the lack of association between cholesterol intake and cognitive scores in non-Hispanic white individuals may be due to their small sample size, leading to false positive results. The results also showed no association between dietary cholesterol and serum cholesterol-related indicators except for HDL. Similarly, dietary fat significantly correlated with some cognitive test scores, but only showed a mild correlation with dietary cholesterol. Overall, varying dietary patterns, as well as other factors such as genetics, lifestyle, and cultural differences, may affect individual abilities regarding absorption or accumulation of cholesterol in blood and neural tissue between non-Hispanic Blacks and whites. To further evaluate the observed association between race, cholesterol, and cognitive function, future studies need to include individuals from more diverse racial backgrounds. A positive association between serum cholesterol and cognitive function was observed in both non-Hispanic whites and blacks, as well as the overall sample, suggesting that higher serum total cholesterol in the normal or slightly higher range could help maintain or improve cognitive function. The cross-sectional design of the survey data in this study was a major limitation as it prevented the researchers from determining whether a causal relationship existed between cholesterol and cognitive performance. Genetic factors and racial disparities strongly influence serum cholesterol and cognition, and the correlations they observed may be due to these factors independent from the direct interaction between cholesterol and cognitive function. Additionally, sole 24-hour dietary reviews may not fully reflect an individual's long-term diet. Additionally, while the researchers adjusted for some confounding factors, it is hard to control for fasting or feeding status, cholesterol-lowering prescription type, or other medications that may affect lipid concentrations and cognitive function, such as psychotropic drugs, beta blockers, and anticoagulants. Finally, omission of statistical interaction before separating by ethnic group may be another potential limitation. Despite these limitations, the study had several advantages. The researchers screened a large representative sample while controlling for potential confounding factors and collecting complete information on various cognitive scores. Although the strength of the associations they observed was inconsistent, even moderately effective interventions could reduce the economic and social burden associated with cognitive impairment and dementia. Furthermore, dietary interventions are relatively low cost with minimal side effects, while serum indicators can be easily measured to predict future outcomes. The results of this study do support the conclusions, as a positive association between serum cholesterol and cognitive function was observed in both non-Hispanic whites and blacks, as well as the overall sample, suggesting that higher serum total cholesterol in the normal or slightly higher range could help maintain or improve cognitive function. Most other research into cholesterol-associated cognitive impairment has focused on hypercholesterolemic patients or animal models and shows varying results. Wardle and colleagues found dietary interventions to control serum cholesterol had no adverse effects on mood and cognition among the British population. Zhu and colleagues found that the relationship between dietary fat and cholesterol intake and the risk of Alzheimer's, dementia, and mild cognitive impairment is almost negligible. Van Vliet found that cholesterol is positively associated with late-life cognitive function, but the association is strongly age-dependent. Thus, the evidence is very mixed. However, all of these studies focused on different populations with a wide range of serum cholesterol values and many taking cholesterol-lowering medications. These results could lead to rethinking current statin recommendations and potentially shifting the focus towards maintaining cholesterol levels within a high normal range rather than aggressively lowering them in this age group, though further research is needed. Current guidelines often recommend statins to lower cholesterol to reduce the risk of cardiovascular disease. However, if studies consistently show a link between higher cholesterol and better cognitive function in older adults, this could lead to a reassessment of the benefits and risks of statin therapy in this population. Additionally, instead of aiming for the lowest possible cholesterol levels, healthcare providers might consider maintaining cholesterol within a higher but still normal range in older adults. This could be particularly relevant for individuals with a history of cognitive decline or those at risk for dementia. This research could also help to undemonize cholesterol, which has developed a generally negative reputation over the years. Lastly, this research can help patients to prioritize disease prevention by eating nutritiously and living a healthy lifestyle instead of waiting until it's too late and needing disease treatment. The role of cholesterol in the progression of cognitive impairment to Alzheimer's disease is complex, and further research is needed into the potential mechanisms underlying the observed relationship between cholesterol and Alzheimer's. This can be achieved through high-quality randomized controlled trials and basic research in neurobiology. While a great number of pathways in which cholesterol can affect cognitive function are well understood, there is still much to be learned. Investigating these mechanisms could provide insights into potential interventions blocking the progression of cognitive impairment to Alzheimer's disease in the elderly population.